So the flow of presentation, I would be going through introduction. I'll be stating the patient who needs systemic therapy, and the we are running 15 minutes late. Try to complete as. Yeah, sure. Then we'll be going through the treatment options for adenoid and non-adenoid cystic carcinoma and role of immunotherapy and conclusions. So, salivary gland malignancy is a rare malignancy, less than 1 to 2% of head neck cancer it constitutes, and surgical management is the mainstay. Now, my talk is dealing with the treatment spectrum for the salivary gland malignancies beyond the surgery, beyond the radiation. And the problem with this particular recurrent metastatic setting is that there is limited trial data, and we are dealing with two different spectrums of disease: indolent disease and aggressive disease. So, as the previous speakers have alluded to, there is a whole list of WHO 2017 types or common subtypes of salivary gland cancers. The most common type is mucoepidermal, constituting 30 to 50%. 20% is adenocarcinoma NOS, 10% is adenoid cystic carcinoma, and 10% is salivary duct carcinoma. The other thing which we need to know is that certain salivary gland tumors are low grade, certain salivary gland tumors are high grade. This was already discussed in the previous presentation. Now, who needs systemic therapy? That is the first question which comes to our mind in a recurrent metastatic setting when a patient presents to us: who is the patient who requires systemic therapy? This is irrespective of the grade of the tumor. All those patients who have a metastatic deposit for which the patient is symptomatic and is not amenable for palliative local therapy. All those patients who have a growth which has a potential to compromise the organ function. And thirdly, all those patients who had a growth of more than 20% in the last 6 months as per the RECIST criteria. Now, when we look at the treatment landscape for patients with salivary gland cancer, we need to classify them as whether they are adenoid cystic carcinoma or whether they are non-adenoid cystic carcinoma. Why this classification is because that's how the treatment has evolved over time. Even with all the recent advances, this basic difference has to be established when we try to decide about treatment for recurrent metastatic salivary gland cancers. So first, let me go into management of adenoid cystic carcinoma. It's the most common minor salivary gland tumor, second most common major salivary gland tumor. It has an indolent course and it has a perineural invasion is a characteristic of this particular carcinoma. Now, the most common genomic alteration which is found in this is alteration called MIB and NFIB fusion, which is due to a translocation of 6-9. Now, in adenoid cystic carcinoma, how does conventional chemotherapy fare? So, in the recurrent metastatic setting, when we use conventional chemotherapy, when we use single agent chemotherapy, we have an overall response rate of only 16%. As in a complete response plus partial response combined is only 16%. And agents like gemcitabine paclitaxel does not have any activity at all. But when we use combination chemotherapy like CAP is cyclophosphamide, adriamycin, and cisplatin, and a combination of cisplatin, minorelbine, overall response rate is 27%. So some improvement is there in the overall response rate. Now, beyond the conventional chemotherapy, can we do anything more by looking at specific targets? So there are multiple targets which have been identified, and I'll be going through different targets. So two important targets which we have found was c-KIT and EGFR. There is 60 to 90% of the adenoid cystic carcinoma has increased c-KIT expression, and similarly EGFR expression is there. But when we look at the trials which looked at use of agents which target c-KIT, we found that the responses, objective response rates are pretty bad, 0% in most of the trials. And the case is same with the use of EGFR directed therapy, whether it is cetuximab, gefitinib, dovitinib, the response rates are bad. So c-KIT directed therapy and EGFR therapy can't be is not preferred. Now, I had mentioned regarding fusion in the adenoid cystic carcinoma, which is MIB NFIB fusion. This leads to MIB overexpression, and this actually, in fact, leads to overexpression of VEGF. So people looked into targeting VEGF. So that is demonstrated in the lab in the lower half of this table. So use of sunitinib, regorafenib, nintedanib again resulted in very poor objective response rates. But when it came to lenvatinib, axitinib, and sorafenib, the response rates are better. It's reaching between 10 to 15% of the responses. And look at the median PFS. It is 17.5 months with lenvatinib. So because of these findings, use of these VEGF inhibitors, lenvatinib, axitinib, sorafenib, is considered one of the options. Now, there are trials which have looked into this. That is, there are trials with pazopanib, there are trials with axitinib, and these have shown that the partial response rate, the objective response rate, comes to almost 10 to 15%. Now, is there any way we can target the MYB directly? So the ATRA which we use in APML seems to have some activity on the MYB expression, and hence it was tried in this phase 2 trial, but that has resulted in in no responses and a median PFS of 3.2 months. So that doesn't work. Notch pathway has been attempted to be targeted. That also has resulted in similar response rate of 10 to 15%. Are there other targets? BCL2 is another target that is still in clinical trial. HDAC inhibitors, mTOR inhibitors, AKT pathway targets have been attempted, but they have resulted in dismal responses. So, in summary, adenoid cystic carcinoma, we can use chemotherapy, we can use target therapy. Between chemotherapy and target therapy, there are no head-to-head comparisons. But from whatever I have presented, what we know is we have good responses with chemotherapy. There are CRs with chemotherapy, but CRs are not seen with target therapy. Target therapy predominantly results in PRs. Survival with chemotherapy or targeted therapy are similar. So chemotherapy is preferred when you need a rapid reduction of symptoms. Otherwise, targeted therapy is preferred. And the preferred targeted therapy in adenoid cystic carcinoma would be lenvatinib, sorafenib, axitinib. Now going on to management of non-adenoid cystic carcinoma. Now non-adenoid cystic carcinoma, again going to conventional chemotherapy. This is the first paper on top is by Dr. Lisa Lisitra, published in 1996, which looked at single-agent cisplatin. The second paper looked at single-agent paclitaxel. We see that the response rate is similar to what we saw in adenoid cystic carcinoma of 16% to 20%, and with pretty poor duration of response. When we use combination chemotherapy, which is cisplatin vinorelbine or CAP or gemcitabine cisplatin, the response rate becomes a little bit more better, but not to the extent what we would expect. So, are there targets which we can use in the non-adenoid cystic spectrum? The three important targets which Dr. Neha had alluded to before: androgen receptor, HER2, and NTRK should be checked. Androgen receptor in the salivary duct carcinoma is found in 80 to 90% of patients. HER2 amplifications and expression is found in 30 to 40% of salivary duct carcinoma. NTRKs are seen specifically in secretory breast carcinomas and mammary envelope secretory carcinoma up to a percentage of 90%. So, targeting androgen receptors. So, androgen receptor targeting has been tested in a prospective phase 2 trial, and what we see is, now you have to put it in contrast to what we saw in the results in adenoid cystic carcinoma. We are getting CRs of
try to complete that.
Yeah. We are getting CRs of 11% and an objective response rate of 40%. And androgen receptor analogs are being compared with the chemotherapy. The results are awaited. So combined androgen receptor blockade is preferred over over isolated androgen blockade. HER2 abnormalities are predominantly HER2 expressions and HER2 amplifications, which are attempted to be targeted by use of trastuzumab docetaxel, which is attempted in a phase 2 trial, and this results in an overall response rate of 70% with a CR of 14%, which results in a median PFS of 8.9 months and median OS of 39.7 months. These are excellent results. But 60% of the patients develop grade 4 neutropenia with this combination of trastuzumab plus docetaxel. Now, use of trastuzumab or pertuzumab was attempted in the phase 2 basket trial. This was a MyPathway phase 2 basket trial, which was a multiple basket trial, of which one of the baskets was the HER2 alterations, in which trastuzumab-pertuzumab combination was used. It resulted in overall response rates of 60% with PFS of 8.6 and OS of 20 months. Adotrastuzumab was again used in another phase 2 basket trial, and that resulted in overall response rate of 90%, with PFS and OS not yet reached in the recently updated results. The best anti-HER2 strategy is not clear, whether it is trastuzumab plus chemo or adotrastuzumab or trastuzumab plus pertuzumab. That is not clear. Any of them can be used based on the availability. NTRK is the new kid in the market. It's predominantly seen in the secretory breast carcinoma and mammary analog secretory carcinoma. Agents are larotrectinib and entrectinib. This was again basket trials done, and in the salivary gland cancers, in which larotrectinib and entrectinib have been used, the response rates are excellent of 80 to 90% with good duration of response, and it's a pretty tolerated regimen. Other targets which can be targeted are HRAS, PTCH1, BRAF. So non-adenoid cystic carcinoma impressions are use targeted therapy whenever possible. Common targets are androgen receptor, HER2, NTRK. Watch out for other targets and judiciously use NGS in these patients. Systemic therapy if target therapy is not available. Now, the big question, whether there is any role for immunotherapy.
Try to complete it.
Just 2 more slides. In the phase 1B Keynote 028 study, which had 26 patients with salivary gland cancers with PD-L1 more than 1%, the pembrolizumab resulted in only 12% overall response rate with the duration response of only 4 months. And another study in which they have used nivolumab, nivolumab did not did not result in excellent response rate. So, in terms of immunotherapy, the response rates are poor, both in the biomarkers selected groups and unselected group. Whether we can use it in MMR deficient and TMB high state based on the FDA label, that is according to the guidelines, it is not recommended. It should be used only in the trial settings. So, in conclusion, classify them as adenoid cystic and non-adenoid cystic carcinoma and use targeted therapy whenever feasible. Thank you.
It's a great talk. Conclusion is should divide adenoid or non-adenoid. If most commonly what we use to in clinic is paclitaxel, we should not use paclitaxel in adenoid cystic carcinoma. That's what I got from this discussion.
Yes. In
non-adenoid, we can use the most common paclitaxel is one of the active agent. In adenoid, we cannot use paclitaxel. And we can use either CAP or vinorelbine. And gemcitabine and paclitaxel are not an active agent with respect to the chemo.